We also have reforms in beverage systems with respect to provider competition. So, uh, in addition to things to address queues, having gatekeeping, and trying to decide how many doctors and hospitals there should be in total, there are also reforms that address the way that hospitals operate and trying to inject competition. A lot of these problems that we've just described, like queues and centralized health technology assessment, they're not really found in countries with private systems. And so some of these beverage systems are trying to experiment with different elements of competition, but still keeping that eye towards solidarity. In general, though, there's like an uneasiness with the idea of using private markets, largely because there is this fear that you'll end up with a two-tier system in which rich patients can use a private system, poorer patients are stuck in a public healthcare system. Especially if the private sector pays better, so the better doctors end up going there, then it would further undermine solidarity and equity. So they try to have reforms that don't do that. Um, in the UK, for example, prior to 1991, hospitals received annual budgets from the government, and the budget was really just a little bit more than whatever your costs were for the prior year. And this leaves really no incentive for the hospital to operate more efficiently or to reduce costs or to reduce wait times. They're just, whatever they spend, they get back. So the reform was that instead of having annual budgets, hospitals would have to compete to get contracts from the government. And those contracts, like to be the provider of certain kinds of services, for example. And then contracts were awarded based on how efficiently the hospital was able to reduce costs, to provide service, and to reduce wait times. And there was some evidence that wait times decreased after this 1991 reform, but they also note that buyers weren't really judging hospitals on the basis of the quality of care. It was on the costs and the wait times. And so that introduces an incentive for hospitals to skimp on quality in order to just like get people in and out, reduce costs, reduce wait times. And so it turns into what they call a race to the bottom. So there was another more recent round of reforms, 0208, where they had these three things: payment by results, some more patient freedom in choosing providers, and then also hospital autonomy and management. They set uniform prices so that hospitals would be competing on quality instead of price, kind of learning from the prior round of reforms. So the first component of the reform was this payment by results system. They compensated hospitals based on the number of procedures, so it removes this fixed annual budget, which can backfire if rates are set improperly. And we'll find that this is a similar situation with other countries that, even outside of the beverage system, but that try to impose price controls to get prices under control. But they were also compensating based on health resource groups, so it's similar to what we have in the United States with diagnosis-related groups. So it's a prospective payment system. And they set reimbursement based on the HRG designation and the patient age, so their medical needs and the patient's age. Prospectively. They also opened up patient choice. Patients used to be assigned to whatever was their closest nearby hospital, kind of like if you can imagine, your closest public high school or something. So hospitals weren't really competing to attract patients, but then they started to give patients freedom to choose hospitals through these reforms. And they also increased managerial autonomy of hospitals. So there was a lot of hospital management constraints. They really could just see whoever, were their nearby patients. But they started to allow hospitals, for example, to treat people outside of the NHS system to accept private pay patients, even if they were NHS hospitals. They would be converted into a foundation trust rather than a direct arm of the government. And it was only high performance hospitals that would apply and become a foundation trust. And those had special levels of autonomy. Much more recently, what's happened 2013 and after is that after the financial crisis, a lot of these hospitals, they were too big to fail. So they were kind of private entities, but ultimately the federal government is the one, or the UK queen or whatever, is the one that ultimately bears the risk, the downside risk of these kind of privatized hospital management decisions. And so when they all needed to be bailed out, they ended up having to accept a lot more public control over their financial management. So in the end, though, for these these reforms, they did find reductions in mortality rates and reductions in wait times. But there was also the opportunity for these like less regulated hospital management structures to grossly abuse that autonomy and to cut corners in order to cut costs. Um, so it turns out that like if you're going to inject this kind of competition, monitoring quality becomes a really important piece of that competition in order to prevent the race to the bottom phenomenon. So in conclusion, for the Beveridge system, we have these three elements of the health policy trilemma, right? Health, wealth, and equity. And the Beveridge model focuses on equity, really maximizes equity and prioritizes solidarity even more than the Bismarck model and definitely than the American model. Problems like wait times and poor incentives for hospitals have motivated some more recent reforms in these Beveridge nations and to experiment with non-Beveridge elements like provider competition and prospective payment systems.